Good morning, everybody, and welcome to HSCC. We're so excited to have you here. And right now, we're going to kick off our kind of pre-conference session with the NPS 101, NPS 2 101, excuse me. And we will have Katie Hoffman present that for us this morning. Many of you probably know her. She's a mother to a beautiful son, Peter, who has Hunter syndrome and is also a pediatrician and is on our Project Alive board. And before we have Katie get going, I just wanted to do a couple of housekeeping things. So, first and foremost, if you look at the very bottom of your screen, you will see a show captions button. If you click on the little arrow there, you can toggle on translations and you would select your translation options that you want to do for whatever spoken language that you might have. So please know that that will be available throughout the entire day today. And if you have questions throughout the conference, throughout Katie's session, at any point, those in the Q&A section. And Katie will try to answer as they come. Otherwise, we'll do a little Q&A at the end of this session. If you have any other questions, please feel free to reach out to us in the chat. And we hope you have a great day, and we'll see you at the formal welcome after Katie's session. All right, Katie, we will let you take it away.
Thanks so much, Kristen. All right, I'm going to rely on Kristen to tell me if I'm not audible or if something's going wrong with my visuals. I am so thrilled to be here this morning. I'm going to share my screen and pull up this presentation. Hopefully you all are seeing this. So as Kristen mentioned, my name is Katie Hoffman. I am a mom of three, including my middle son, Peter, who has neuronopathic Hunter syndrome. We've been part of this community since 2019 when he was diagnosed. We live in Marin County, California, which is just north of San Francisco. And as Kristen mentioned, I'm a general pediatrician. I work as a pediatric hospitalist, so a hospital-based pediatrician here at our local community hospital in Marin County. And without further ado, I'm going to get started talking today about Hunter Syndrome 101. If you happen to attend this session last year, a lot of this will be review. So feel free to grab a cup of coffee or tune out for a bit and come back for the formal welcome, or perhaps this is going to be a great review for you. I am hoping to make this a presentation that is intelligible to a wide audience. So I expect that hopefully in this conference, we will have participants who are family members, caregivers, perhaps Hunter syndrome adults themselves, as well as providers, medical providers, therapy providers, educational providers, and caregivers, and perhaps also some of our advocates or pharmaceutical partners as well. So let's see here. All right, so my disclosures first off. So I'm a general pediatrician. I am not a metabolic geneticist. That means that I am speaking from the perspective of a general pediatrician rather than a specialist in Hunter syndrome and lysosomal storage disease. I am a Hunter syndrome caregiver. I'm a mom. This is my son, Peter, one of my favorite pictures of him from several years ago. And everything that I'll be presenting today is publicly available information. It's accurate to the best of my knowledge. Any discussion of treatments that we're going to have today will be as objective as possible. I'm not intending to recommend or to preference any particular treatment over another. So quick outline for today, we're going to start with kind of what is Hunter syndrome. We're going to go through kind of from inside out. So starting with the microscopic level genetics and biology, we'll go through diagnosis, signs and symptoms. We'll talk about management as a caregiver or provider for someone with Hunter syndrome. We'll talk about currently available therapy, specifically targeting Hunter syndrome, investigational therapies, and then the future of Hunter syndrome. We'll be pretty light on the content at the end because we'll have a lot more later on today in our conference. So, what is Hunter syndrome? I just want to start with some photographs because I think that most importantly, we're going to get into the weeds of the biology and the genetics, but most importantly, this is a condition that affects human beings. These are our children, our friends, and family members, and I feel like it's important to represent the spectrum of Hunter syndrome. So this is Hunter syndrome. All of these children and adults represent our community. So to get started, I will highlight just these three kind of VIP Hunter syndrome folks this morning. The top two are relatives of our executive director, Kristen Stockin, her late brother Zachary at the top, and her adorable son Charlie in the middle. And then finally, our chairman of our board of directors, Kyle Underwood, who is an incredible representative for our adult MPS II community. So what is Hunter syndrome? So Hunter syndrome is mucopolysaccharidosis type 2. You've probably heard that term. You've probably also heard it abbreviated MPS type 2 or MPS 2. And what is that? Well, as a physician speaking to another physician, you might say it's a rare genetic lysosomal storage disease that causes progressive multisystemic organ damage, can be neurodegenerative, it's life-limiting, there's no cure. What the heck is that? That doesn't sound like English or very intelligible to most of us. So let's break this down a little bit. To start with, what does it mean that it's rare? Well, the information kind of published in various sources suggests that about 1 in 100,000 to 1 in 170,000 live births are affected by Hunter syndrome or MPS type 2. What does that mean kind of on a more concrete level? Well, if there are about 3.6 million births in the United States each year, in recent years, less than 30 babies, maybe even less than 20 babies are born every year in the United States. That's less than one per state. So that totals to kind of less than 500 living individuals in the United States and probably about 2,000 individuals worldwide. So we are rare, but we have a very tight-knit community, and that's why we're here today to join together to learn from each other and to support one another. Secondly, genetic. Hunter syndrome is a genetic condition. Who is affected? Mostly males. You might have noticed in the photographs that all of those photographs were of boys or men. And why is that? Well, that has to do with the genetics. Hunter syndrome is inherited in an X-linked recessive pattern. So what does that mean? You may have seen kind of these general genetic diagrams for male and female being represented by XX and male being represented by XY. And to get into what that means, on the left, there's a human female karyotype, and on the right, there's a human male karyotype. So this is a representation of chromosomes or your genetic material. We all have 46 chromosomes, so that includes 22 pairs of somatic chromosomes that are numbered 1 to 22. Each one of each pair is inherited from each of our parents. And all of those chromosomes look essentially the same in males and females. But then there are 2 sex chromosomes and one inherited from each of our parents also. And girls have 2 X chromosomes and boys have 1 X chromosome and 1 Y chromosome. Why is that important? Well, there's duplicate information that's carried on the pairs of chromosomes, and that's helpful for maintaining health. But boys don't have a second X chromosome, and that's what leads to the issue in Hunter syndrome. So in an X-linked recessive condition, a mother or a woman who has 2 X chromosomes can have 1 X chromosome that's affected with the gene for Hunter syndrome, and one that is a healthy or unaffected X chromosome. So she, because she has a healthy chromosome, healthy gene, she will not manifest any symptoms of Hunter syndrome. She will not be affected by the condition. However, if she passes the affected X chromosome to her male child, then that child will be affected. And because she has two X chromosomes, for any given pairing of male and female genetic material, there's a 25% chance that there will be an affected Hunter syndrome child. Of the 50% chance of having a male child, 50% of those male children could be affected by Hunter syndrome. I know that that's still very confusing and goes back to a lot of the genetics and biology that you learned perhaps in high school or college. So it is a complicated thing, but it's very important to understand in terms of how this can affect families, particularly because it can remain silent or unnoticed for generations if there is no affected male in a particular generation, and the carrier gene can be passed from female to female in each generation. So this is an example here of an affected son with Hunter syndrome. So getting a little bit more into the biology, just a quick review. So all of us, our organ systems, our bodies are made up of cells, and those cells have a nucleus in the center. That's the dark gray represented on the left here. Inside the nucleus, we carry our genetic material, and that is stored in these chromosomes. Chromosomes are made up of DNA, and that's the double-stranded molecule with the letters AGCT that you may have heard of. And a gene is a sequence of DNA that codes for something specific. So what is the gene problem in Hunter syndrome? So kind of going from left to right on this slide, we have the genetic material in the nucleus of the cell, the X chromosome represented, and on the X chromosome, there's a particular gene or DNA in a sequence that codes for IDS. And that is the name of the gene that carries the genetic material that codes for the enzyme that is missing in Hunter syndrome. This representation on the right is just a visual representation of the number of different problems that can happen within the gene that can lead to Hunter syndrome. So this is why there is such wide variety in how Hunter syndrome looks and how it progresses, because the genetic problem can be so variable. And what is the enzyme problem? So once the IDS gene codes for a protein or an enzyme, that is a protein that performs actions in a cell. And in this case, the IDS gene codes for an enzyme called iduronate 2 sulfatase, which is sometimes abbreviated I2S. And that protein is made up of a bunch of amino acids that are folded together in particular ways. And depending on the genetic problem and the coding issue in creating this protein, the folding can be different. So you can have a malformed protein or enzyme, or you can have a missing enzyme if that gene is missing altogether, or if the coding is so messed up that it can't form the enzyme. So we're already getting into a lot of terminology and kind of alphabet soup here, but another buzzword that I mentioned when we asked the question, what is Hunter syndrome, is that it is a lysosomal storage disease. So what does that mean? A lysosome is a little part of a cell outside the nucleus, which contains the genetic material. The lysosome is like a recycling center in cells. That's at the simplest level how I like to think about that. And in that lysosome, there are a number of enzymes, which are the machinery of the recycling center. I2S, or iduronate 2 sulfatase, is one of those machines or enzymes. What does that enzyme act on? Well, it acts on mucopolysaccharides. And what are mucopolysaccharides? Muco refers to kind of a thick jelly-like consistency of the molecules themselves. Poly is many, and saccharide is kind of a general term for a sugar molecule. So these are chains of sugar molecules that are used to build connective tissue and other things within important things within the cell and the body at large. Another term for mucopolysaccharides is glycosaminoglycans, which is abbreviated GAGs, GAG. And that is kind of the more common term used now, although obviously the name mucopolysaccharidosis comes from mucopolysaccharide. But those are interchangeable. And there are many different kinds of these sugar molecules. In Hunter syndrome, the relevant ones are called heparan sulfate, abbreviated HS, and dermatan sulfate, abbreviated DS. And these are the particular GAGs, or long sugar molecules, that build up within the lysosomes when we have Hunter syndrome. So on the left in this picture, there's an unaffected cell. The cell has a nucleus with its genetic material, a recycling center lysosome, has plenty of these little yellow I2S enzymes functioning to break down these GAGs, HS and DS. In a cell affected by Hunter syndrome, again, there's a genetic problem going on in the nucleus, leading to a deficiency of enzymes. So there's very little of the yellow enzyme here, and these GAGs, HS and DS build up. And you can see that this cell looks pretty bloated. The kind of recycling can't happen efficiently, and that causes a lot of dysfunction within the cell and then in the body at large. So just kind of reviewing all of this very complicated information we've been going through. In Hunter syndrome, there's a gene defect leading to an enzyme deficiency, leading to GAG accumulation and causing a lysosomal storage disease. So to summarize, just in one other kind of visual way, the gene defect in Hunter syndrome is in a gene called IDS that is located on the X chromosome. That leads to an enzyme deficiency or absence, and that enzyme is called I2S. That leads to GAG accumulation within the cells, and those specific GAGs that build up are called HS and DS. And that, in summary, leads to the lysosomal storage disease that we call MPS II or Hunter syndrome. So there's your biology for the morning. There's a lot in there. You will be able to take the first step of your pediatric and perhaps even your metabolic genetic board exam now. But I think that it's important to recognize some of those terms and become a bit familiar with them, because it will be particularly relevant to understanding the symptoms in Hunter syndrome, how we manage it, and the potential treatments that are available or that are in development. And you'll probably hear a lot of these terms as we go through the day today. So because it's really relevant to the biology and genetics that we just discussed, I want to talk about how Hunter syndrome is diagnosed next. So there are kind of three main tests to confirm a diagnosis of Hunter syndrome. The first is a measurement of the GAGs, that substance that builds up in excess in Hunter syndrome. It's easily measured in urine. And so for a patient with Hunter syndrome, they will have elevated levels of HS and DS GAGs in their urine. There is also a blood test that can look for I2S enzyme. And so for a Hunter syndrome patient, there would be low or even undetectable enzyme level in the bloodstream. And often when you're getting that test performed and making a new diagnosis of Hunter syndrome, your physician may also test other lysosomal enzymes just to confirm that those are normal and to make sure that you don't have another condition affecting multiple lysosomal enzymes. And then finally, there's a molecular test that actually can sequence the genetic information on the IDS gene and would demonstrate a mutation or a genetic problem there. So these are all tests that can be performed on someone after symptoms are present. Once you have a suspicion for Hunter syndrome, you can get this testing done and make a diagnosis of Hunter syndrome. But how about making a diagnosis before symptoms are present? or if you suspect a child is at risk of Hunter syndrome based on family history, but does not have symptoms yet. So a couple of things that can be done in terms of diagnosis before symptoms are present. The first is newborn screening. And this is a really important thing that I believe we'll get into a little bit more later in the day as well. But any of you that have had children may be familiar with dried blood spot testing. So it's taking a little sample of blood from usually a heel prick of the newborn, putting that blood on filter paper, and that dried blood spot can be tested for a variety of rare metabolic conditions. And so that is one way that Hunter syndrome could be diagnosed, and is in development currently, or rapidly expanding in terms of access. The second thing I wanted to mention is that Hunter syndrome can be diagnosed prenatally. So for a woman who is pregnant, you can actually do testing on the fetus via two types of obstetrical tests. One's called chorionic villus sampling, and one's called amniocentesis, which can be done during the early to mid second trimester of pregnancy. That testing would involve looking at the gene sequencing of the IDS gene to identify a problem. The second thing that can be done prenatally is if a woman is undergoing in vitro fertilization, embryos can be tested for problems in the IDS gene specifically. With newborn screening, the typical testing involves a measurement of GAGs first, a measurement of enzyme, I2S enzyme level first tier, and second tier confirmatory testing with measurement of GAGs in that dried blood spot. So these are all kind of the forms of testing that are currently available and used for Hunter syndrome. So let's go back out from the microscopic level and talk a little bit about how Hunter syndrome affects the human body. So a couple of other buzzwords from that original definition: multisystemic, progressive, and neurodegenerative. So let's kind of dive into what these things mean. So Hunter syndrome touches every organ system in the body because every single cell in the body lacks the enzyme and therefore has the abnormal buildup of GAGs. So there's really no part of the body that is spared. However, certain parts of the body are affected more than others, or more noticeably than others. And specifically, I just wanted to point out that the neurologic system, in a variety of ways, the airway or the respiratory system is affected significantly, the heart, and then the bones and joints. And we'll dive into these, each of these a little bit more to talk about how folks are affected. So this is just an incredibly busy diagram of many different organ systems in the body that can be affected, but I kind of want to highlight them based on those major organ systems that I mentioned. So to start with the neurologic system, actually, I'm going to skip over the neurologic system. We'll get back to this because there's a lot. We'll start with kind of the airway and the respiratory system. So the airway can be narrowed because of kind of inflammation or narrowing of the airway just related to GAG buildup. There can also be enlargement of the tonsils and the adenoids. That can lead to chronic runny nose. It can lead to recurrent respiratory infections because respiratory secretions can't be cleared very well. It can lead to recurrent ear infection. Believe it or not, ears are sort of connected very closely to the respiratory system. That means that many children require ear tubes. They require surgery for removal of adenoids and tonsils. And then there can also be lower airway disease, the smaller airways leading to the lungs, and then even the lungs themselves can be affected by restrictive lung disease kind of later in the course. Next, mentioning the heart. So many kids with Hunter syndrome might have a heart murmur, or you might have heard that described by your pediatrician or physician. And the kind of two potential causes of a heart murmur, the two potential major issues in the heart related to Hunter syndrome. The first can be valve problems. So there are a number of valves that separate the chambers in the heart. And those, due to the buildup of GAGs in that tissue, can lead to either stenosis or kind of stiffening of the valves, which leads to a problem with opening of the valves, or it can lead to leakage of the valves, which is a problem with closing those valves. And the other problem is cardiomyopathy, which is kind of a disease of the heart muscle itself, which just impairs the ability of the heart to kind of pump blood effectively to the body. So any of these things can obviously lead to significant symptoms or problems. And this is something that is progressive over time because that GAG buildup progresses with time. And so the symptoms get worse over time. The next thing I want to mention is kind of impact on bones and joints. So joint stiffness and restricted mobility of joints can be really prominent, again, progressive over time. So the older someone is with Hunter syndrome, the more noticeable this will be. There are stiffness in the kind of small joints, particularly fingers and toes, which can make the fingers kind of look like claws. Or be kind of distorted in a curved position. There are other kind of bone issues that are not as obvious on the outside, but can be seen on X-ray. And in some, those are called dysostosis multiplex by physicians. And then all joints can be stiff and have difficult range of motion: shoulders, elbows, wrists, knees, hips. There is particular tightening of the heel cords and stiffness in the ankles, which can lead to toe walking in a number of patients. And then actually, I'm realizing it's not on here, but hip dysplasia or kind of abnormal formation of the hip joint is also an issue. And then kind of everything else can be affected in Hunter syndrome. There are eye symptoms that, again, tend to occur later in the progression of Hunter syndrome. There can be impacts in the gastrointestinal system. So there can be umbilical or inguinal hernias, which are kind of protrusions of the belly button or protrusions in the groin due to weakness in the abdominal wall. There can be enlargement of the liver and spleen. And even recurrent kind of watery diarrhea and digestive issues. Then characteristic pebbling of the skin, I intended to actually cross that out. That's not something that we commonly see in this condition anymore because of treatments and sort of earlier diagnosis and management of the disease, which is great. I hope to see less and less of these symptoms over time. So I just want to go back to kind of what are the earliest and most common symptoms and signs of Hunter syndrome. And I like this graphic because I think that one of the most challenging things that often leads to a delay in diagnosis for particularly children with Hunter syndrome is that this is a combination of relatively common childhood conditions. But the combination of those common conditions is rare and should prompt a provider to think about a unifying diagnosis such as Hunter syndrome. Typically, diagnosis in Hunter syndrome is made between kind of 2 and 4 years old once symptoms have really started to develop and evolve. So some of these earliest symptoms can be kind of large head size, distinctive facial features, which I'll show in a moment. A lot of children are noted to have kind of these respiratory symptoms early in life. So frequent runny nose, respiratory infections, ear infections. perhaps multiple surgeries for ear tubes or for removing the tonsils and adenoids, tonsillectomy, adenoidectomy, perhaps sleep apnea at a very young age. Other things that can come up are hearing loss, speech delay, or other developmental delays, which again can be related to a number of other causes in childhood, but in combination with some of these other symptoms should prompt kind of a further workup. And then finally, many sort of toddlers or young children are noted to have kind of a very large belly due to that enlargement of liver and spleen, perhaps have had some hernias. Short stature is relatively less common at the young ages, but can be present. And then stiffness of the joints or curvature of the fingers can lead to kind of a diagnosis. And this is a just sort of visual progression of a single child kind of over the course of time from age 6 months up to age 6, which was the time of diagnosis in this case. And so you can see kind of an evolution of facial features, which many of our children or Hunter syndrome patients share. That's including a broad nose, some flaring of the nostrils, kind of these ridges above the eyes, thickened lips or very large lips, large jaw, and a very large head circumference, or macrocephaly, large head. And then enlarged tongue, I kind of added on there because that can also be present, although again, generally not as much in the youngest children. Just to show you kind of the sort of personal diagnostic journey for our family. My son Peter was diagnosed just after 18 months old, and his kind of presenting symptom was a very large head, in addition to a little bit of an enlarged liver, and then some speech delay, which led to a diagnosis of hearing loss. And this is a growth chart because pediatricians love growth charts, and many of you have probably seen a growth chart. If you have a child yourself, on the x-axis is age, on the y-axis is head circumference. And as you can see, at birth, my son had a head circumference that was at the 50th percentile, or very average. And over the first year to year and a half of life, his head grew well above the 97th percentile. And then these are kind of photographs of him from the age of just a couple months up to 18 months when he was diagnosed. And you can kind of see the evolution of some of those common facial features for him. I would say that, you know, we just thought he was a particularly cute kid, and we would not have necessarily called out any of those facial features as abnormal in and of themselves. Also, he was a chubby guy and had a big belly, but again, nothing that by itself raised concern for us, even for myself as a general pediatrician. So I hope that that kind of gives you a little bit of a picture of kind of what Hunter syndrome can look like, what the early symptoms might be, and how it can be diagnosed. I want to get back to the nervous system, or how Hunter syndrome affects the neurologic system, because I think this is one of the key areas of, targeting for treatment in our treatment landscape, and some of the greatest unmet needs for our community. So Hunter syndrome affects the nervous system, or affects the neurologic system, in terms of, number one, developmental delays early on, and that can eventually lead to severe cognitive impairment. So again, this is a progressive condition. About 2/3 of children with Hunter syndrome have the neuronopathic form, which I will just show that now, which has historically been called kind of the severe form. And that means that the cognition or the brain is more severely impacted. On the other end of the spectrum is the attenuated form, which has historically been called the non-neuronopathic form. And that's about 1 in 3 patients with Hunter syndrome. And in that case, the brain or cognition is not impacted by the disease. However, the body is impacted the same way as any patient with Hunter syndrome. And so the disease can be just as severe physically, but it does not have the same cognitive progression. And I just kind of wanted to show this rather than a dichotomy, which is how we used to think about this, that there were 2 types of Hunter syndrome. 2/3 of patients had severe, 1/3 of patients had attenuated. Really now we understand this more as a spectrum, and that there's a lot of variability even within one or the other of these general types of Hunter syndrome, and there is even a lot of gray in the middle, particularly as our treatments advance. So just going back to kind of other neurologic symptoms of Hunter syndrome, particularly in the neuronopathic type, there are a number of behavioral symptoms in addition to cognitive challenges. And then kind of on the physical side of the neurologic system, hydrocephalus, which is kind of blockage of the flow of spinal fluid and fluid around the brain, that can lead to increase in pressure in the brain, can be really significant, sometimes requiring surgery to place a shunt to help that flow of spinal fluid. There can be spinal cord compression at the level of the cervical spine, kind of at the level of the neck. That can sometimes lead to neurologic symptoms in the rest of the body and can require surgery for decompression and stabilization of the cervical spine. Carpal tunnel syndrome, you could kind of put that into a musculoskeletal system or into the neurologic system, but carpal tunnel syndrome is compression of the median nerve in the wrist, leading to symptoms in the hands. And that can require surgery, sometimes repeated surgery due to the progressive buildup of GAGs. And then lastly, seizures can be an issue, again, more common later in the course of disease, and a less common symptom, not always present. So just to look a little bit closer at the kind of natural history of development and the developmental consequences in the more severe or neuronopathic form of Hunter syndrome. So on the x-axis is age, going from kind of less than 2 years old up to greater than 8 years old. On the y-axis is development, and this is a score, kind of an age equivalent score. So how mature is the child, kind of based on age. A normal trajectory, as you might expect, is kind of a line going from the lower left to the upper right. As you get older, you get more developed or more mature, more cognitive skills. In Hunter syndrome, there is a trend that mirrors normal development for a period of time, perhaps with some delays right from the get-go, but a progression of cognitive development for a number of years, and then kind of a prolonged period of slow or no development, a plateau that occurs somewhere between kind of 4 and 7 years old, and then a decline in cognitive skills. And due to that progressive disease in the brain, there's a progressive loss of skills, both physical and cognitive skills, similar to what someone might experience in progressive dementia. So neurobehavioral symptoms can be a real challenge for those of us who have children with the neuronopathic or severe type of MPS II. And I hope that in future iterations of this conference, we'll have kind of a lot more to say about this. There has not been a lot of intensive kind of research or consensus on how best to describe or manage these behaviors, but they can be really challenging and really disruptive to life for families with Hunter syndrome. So some of the sort of typical features that we see are inattention, hyperactivity, impulsivity. That can look a lot like severe ADHD or attention deficit hyperactivity disorder. There can be a lot of emotional reactivity, defiance. There can, because of the combination with developmental delays and cognitive impairment, this can also look somewhat like autism. And some of the kind of initial research that's been done by Julie Isengard at Minnesota has looked at some of these most challenging behaviors in an attempt to kind of describe what they are and how they manifest, and what the etiology or what the background of these symptoms might be. So some things that this is just one example of that, but a child with Hunter syndrome, because of this combination of behaviors, may be interpreted or may appear to be very aggressive because they are doing things like grabbing, throwing, biting, kicking, pushing. But in fact, some of these behaviors may actually have other purposes for that child. It may be a sensory seeking, it may be a social interaction attempt or a form of communication. It may be just an abnormal behavioral response, difficulty regulating the behavioral system. And so it's a very complicated problem. And that means that there's not an easy solution. And I wish that I could tell you the consensus for management of these behaviors, but often there is a combination of behavioral therapies, supports, education, coaching, and counseling for parents and families, supports like one-to-one aids to really work with children on a really one-on-one personal level, as well as medications, although there's no consensus on kind of which medications are most beneficial. So how is Hunter syndrome managed over time? I am realizing that I need to kind of speed up a little bit so that we have time for Q&A at the end. But Hunter syndrome management is really complicated because, as we talked about, Hunter syndrome is very complicated and affects every part of the body and brain. So really, there are a number of different medical visits and procedures or testing or surveillance exams that are needed for Hunter syndrome over time. And we're not going to go through this table, although I think that there are very helpful references for providers who are not metabolic geneticists or not MPS specialists who are caring for a child with Hunter syndrome and want some guidance on kind of how to help that child stay healthy over time. For families, we have some resources on the Project Alive website, trying to kind of outline in checklist form the most important specialists or medical visits that families need to have in the first year after diagnosis, then annually, in order to stay healthy and stay on top of the condition. Things are a little bit different for someone with attenuated versus attenuated versus neuronopathic MPS II. And so those checklists look a little bit different. Then finally, for the 1 in 3 Hunter syndrome patients with the attenuated form, we have some Journey into Adulthood resources, which I think is really important because that's a very different transition than folks with neuronopathic MPS type 2 are making as they reach adulthood. Um, so I think of Hunter syndrome management as a team sport. There are so many different medical specialists, and on this next slide, therapy providers, educational specialists, and then also kind of mental health providers and community supports for Hunter syndrome. And this can be really overwhelming for a family that is just getting this really difficult, devastating diagnosis to try to stay on top of uh, coordinating care with all of these different specialists, uh, advocating or finding and taking advantage of all of the different therapeutic and educational supports that their child might need, in addition to just managing home life, activities of daily living, sleep, and trying to perhaps have a career or take care of other children as well. So, um, really, um, there are so many folks that make care for someone with Hunter syndrome uh, much more doable day to day. We are so incredibly grateful for all of those different providers that come together and form that team. But I would also say it's just very difficult to coordinate care amongst this number of different medical specialists, some of whom might not be as familiar with Hunter syndrome or lysosomal storage disease, or might have different or conflicting information to share with you. Often a parent or caregiver becomes kind of the care coordinator. Um, but I would really encourage families to try to find a uh, a single physician, a provider, someone in the medical system who can kind of be your point of contact and can help serve as that coordinator and connector for referrals to other specialists who can help you to stay on top of the different specialists your child might need to see, the different procedures they might need to have, and then to really coordinate care between those. And then finally, like all of these different therapies and educational specialists, some of them require referrals if you have insurance. Some of them have requirements for assessments, for maintenance of therapy. So this is just a very time-consuming process. And so having someone who can help coordinate that would be wonderful. Often it is a parent or caregiver. And I really encourage those parents and caregivers who are struggling with this to reach out in community, because this community has a wealth of experience and expertise and can really help you to um, uh, figure out how to best navigate this complex system. Briefly, I just want to mention late complications of Hunter syndrome. So we mentioned that it's a progressive condition, and those major organ systems that I mentioned, the brain, the heart, and the airway or the respiratory system, are the most impacted over time from the progressive condition. And so neurologic deterioration like dementia, heart failure, or respiratory failure are the largest complications causing issues for patients late in their course of Hunter syndrome. This is a little bit of a scary graph on the right. This just shows survival with MPS type 2, with this very steep decline in survival in the first to second decade of life. I want to mention specifically that this is data collected from the last half century and the early 2000s. And this graph is really no longer relevant to our community today because of the newer treatments that we're about to talk about. And that is an amazing evolution, but historically, this is just a really incredibly devastating condition because survival beyond the second decade of life was rare. So what are the current therapies that we have in addition to all of those supportive therapies and medical treatments that we can do? The first thing I want to mention is enzyme replacement therapy, which is the one FDA approved form of medication specifically targeted to treat Hunter syndrome. The second thing that is a form of treatment for Hunter syndrome is hematopoietic stem cell transplant. And sometimes that's abbreviated HSCT. Enzyme replacement therapy is abbreviated ERT. And there are a couple forms of HSCT that I will mention. I'm not going to touch on therapies that are available outside the USA because I'm not particularly familiar with these, but there are other forms of ERT and some newer versions of ERT available outside the US. So just looking at ERT, enzyme replacement therapy, a little more closely, Elaprase or idursulfase, as the generic name, is the commercially available product. It's made by a company called Takeda. Some folks that have been receiving this enzyme for a long time remember that it was originally manufactured by Shire that was acquired by Takeda. And the mechanism of action of this is essentially just a synthetic form of enzyme that is missing in all of the cells in a patient with Hunter syndrome. So I don't even know if you can see my cursor, but in this example, there's kind of a healthy cell here, and the red represents the enzyme I2S in a healthy cell, and that's causing the normal recycling of GAGs, the little purple molecules in these little brown potato lysosomes. In a Hunter syndrome cell, you can see there's no red I2S enzyme. There's a buildup of the purple GAGs. Those lysosomes are large, and this cell is kind of not functioning well. Here, you've added Elaprase, synthetic enzyme, to the body. It is taken up by cells and brought into the lysosomes and starts to break down those GAGs. And so with Elaprase, you are able to get a cell functioning much better than it was because you've provided the enzyme that was missing. This has been a really life-changing treatment for the Hunter syndrome community. It was approved in 2006, so a number of older patients with Hunter syndrome have been receiving it since that time. Almost any newly diagnosed patient is receiving it. Because this enzyme is a large protein and it is not naturally manufactured by the body, it is also metabolized out of the body very quickly. And so this medication needs to be given weekly in order to maintain effect. And that's weekly forever or indefinitely. There's not a length of treatment after which you can stop this therapy. It does need to be administered directly into the bloodstream. And so that requires either a peripheral IV to be placed into a vein or a port or a central catheter to be implanted in the chest in a large vein so that this can be administered. So there's a lot involved with that. The next thing I want to mention is hematopoietic stem cell transplant. There are a couple places that you can get hematopoietic stem cells in the body. One is from the bone marrow, often extracted kind of from the large bones in the hips. The second is kind of from blood that is specially processed, and those stem cells are extracted. And the final way is from umbilical cord blood, and there are sort of banks of umbilical cord blood containing these stem cells available, at least in the United States. And once you've collected those stem cells, they're processed, they a patient with Hunter syndrome would receive chemotherapy in order to wipe out or eliminate their natural bone marrow. And then these stem cells are infused in, and those stem cells find their way into the bone marrow and settle in and form a new bone marrow for a patient with Hunter syndrome. Cells from the bone marrow can be are secreted from the bone marrow, circulate in the bloodstream, and differentiate into many different kinds of cells that form our immune system, our red blood cells that carry oxygen. And some of those cells migrate out of the bloodstream and into tissues, and those then form a permanent part of those other organ systems. And the idea behind hematopoietic stem cell transplant is that the enzyme from these cells that have normal, healthy enzyme production in the new bone marrow can be excreted from those stem cells and be taken up by other cells in the body and in the bloodstream, and can cross correct some of those other cells. And I am completely out of time. I'm just going to mention very briefly that, and it doesn't look like I have any questions, so at least that's a good thing. But let me mention briefly that there are a couple of different forms of newer treatments that are in study now and that are potentially can provide greater benefit to our Hunter syndrome community. So the first that I want to mention is kind of new ways of providing ERT or enzyme replacement therapy, particularly allowing it to cross into the central nervous system. One of the problems with Elaprase is that because the protein or the enzyme is so big, it cannot get into the brain and cannot correct cells in the brain very effectively. And so there are new ways of administering ERT that are in clinical trials being administered to patients with Hunter syndrome now, that allow that enzyme to be carried into the brain. And we will hear more about that later today. The second type of therapy that is currently actively being studied is gene therapy, and there are two forms of gene therapy. I am going to skip ahead because I am out of time now. And I just want to mention the couple of the sessions later today that will highlight some of the things I did not have time to talk about this morning. We talked a little bit about Hunter syndrome management. There are going to be some really great sessions later this morning on neurocognitive testing and a caregiver panel, which are really going to touch on a lot of elements of managing not only day to day, but helping to follow care over time. And then treatments. We're going to have a lot of sessions today looking at novel treatments for Hunter syndrome and really dive into the details of how these investigational treatments work and how they are how clinical trials work in order to get these treatments into patients. And then finally, really important kind of how do we plug in, what can we do, and what's next for Hunter syndrome. And I think there will be some great sessions on advocacy and then unmet needs in our community that Kristen will share with us later today. I want to just say thank you so much for your time and attention this morning. I apologize that we spent too much time on the genetics and biology and not enough time on the clinical elements. And I will revise this for future, and please submit feedback through Project Alive staff so that we can optimize this talk for the future and make this most beneficial to you. We don't have time for Q&A, but I just want to show just one last slide with several more faces of Hunter syndrome, because these are the folks that make up our community and the reason that we're here today. So thank you all so much. I'm going to stop sharing my screen and turn this back over to Kristen.
Thank you so much, Katie. And if anyone does have questions, feel free to put those in the main chat area. Katie will be on, and I'm sure she'll be happy to answer some questions there or reach out to you. Or as she mentioned, feel free to reach out to us as well, and we can pass those along. So now we are going to go ahead and exit this room and head on over to the welcoming. Unfortunately, we don't have a main stage like we have in past years, so you will need to kind of toggle through the rooms as we go through the agenda. So I will see you all there for the opening address. Thank you so much.